induced for medical purposes. بالعادة pregnant lady المين إيش اللي بتيجي عندها للمستشفى اللي هي الألم الطلق، فبالتالي إحنا المفروض نستخدم الأنجيزيا والأنستيزيا. والجول تاعها إنه to provide effective pain relief for the mother in a safe way. Safe way معناته في عنا minimal or no adverse effects on the progress and outcome of pregnancy and labor. about the maternal mortality الأنستيزيا قللتها لحد ما يصير في عنا أقل من 1 لكل 500,000 من المذرز. Now we will talk about another topic, which is the impact of analgesia and anesthesia on pregnancy regarding all the systems. First system that we will talk about is the central nervous system. Pregnancy alternate the anatomy and the response to pain and pharmacotherapy. So بسبب هذا الشيء بصير في عنا hyperventilation during labor might result in hypocapnia and dizziness. So the use of inhalation agents that induce lightheadedness and nausea might be delayed during labor. The pain also during the first stage of labor is conducted along the sympathetic fibers, which is from the T10 to the L1 fibers. So solutions that permit ambulation can be used while trying to avoid motor block to minimize any adverse effects on maternal expulsive efforts in the second stage of labor. الليبر في عندها طبعا 4 stages هنحكي عنهم بآخر جزئيتي، بس إنه الفيرست stage بدنا نعرف إنها هي من ال time of diagnosis of labor to full cervix dilatation, but the second stage is the time from the dilatation of the cervix to the time of delivery of the fetus. Okay. Now about the neuroaxial anesthetic requirement are reduced during pregnancy due to the distension of epidural venous plexus هنحكي عنها هلا. Okay, what about the cardiovascular system? So there is physiological changes, which is include increase in the plasma volume. بصير في عنا هون delusional anemia. في عنا برضه peripheral vasodilation, which causes a decrease in systematic vascular resistance and increase in cardiac output in order to maintain the normal level of arterial pressure. Regarding anesthesia, شو بتعمل anesthesia بالcardiovascular? There is peripheral vasodilation, which help in the venipuncture and intravenous cannulation. There's also dilated epidural veins اللي حكينا عنها can interfere with epidural anesthesia. Lastly, there is higher risk for developing aortocaval syndrome when the pregnant lady is in a supine position. هلا حنحكي عنه هذا السندروم. So the definition of this syndrome is the lack of blood flow back from the lower extremities to the maternal heart and central circulation due to the compression of uterus on the inferior vena cava and the aorta. اللي بيصير عنا إحنا إنه بيصير في عنا decrease in the venous return and in diastolic volume and stroke volume. So the clinical manifestation of the syndrome is the tachycardia, late bradycardia بالأخير بيصير في عنا bradycardia, pallor, diaphoresis and nausea و hypotension و dizziness. هلا هون اللي حكينا عنها لما يكون pregnant lady light supine بصير في عنا aortocaval compression. This might reduce the maternal cardiac output and compromise the placental perfusion. How we can manage it? It's relieved by tilting the abdomen laterally like in this picture below. Now about or regardless the respiratory system, the pregnant lady have a higher risk for airway complications. They have higher chance for failed intubation. That's because pregnant women have higher weight and also have has higher weight and has larger breast. An increase also in the oxygen consumption بيصير عنا و decrease in the function residual capacity resulting in a lower oxygen store. There is also aspiration can develop. The impact of pregnancy on GI system. It can cause regurgitation and aspiration of gastric content due to the gradual displacement of stomach and intestines by the growing uterus. There's also risk to have heartburn. That's because decrease in the esophageal sphincter tone. في عنا برضو كمان delayed بالgastric emptying. الديليد هذا بيصير بسبب الستريس اللي بيصير عندنا بالمرأة الحامل والuse of the opiate drugs. What about the effects of pain on mother and her fetus? Mother senses the discomfort. Also, there is maternal hyperventilation during the contraction, which cause respiratory alkalosis. Respiratory alkalosis result تاعها بصير في عنا shift of exohemoglobin dissociation to the left, as we see in this picture. And بسبب هذا الشفت بصير في عنا increase affinity of maternal hemoglobin for oxygen، وبسبب الافينيتي اللي زادت عند الماتيرنال للأكسجين صار في عنا decrease بالأكسجين offloading to the fetus. Regarding the pain, also there's hypoventilation syndrome, which blowing of carbon dioxide during a contraction. Then she or the pregnant lady hypoventilate between the contraction, which might lead to mild hypoxemia. Labor pain increases the level of circulating catecholamine اللي هي بتكون alpha والبيتا 2 adrenergic. The effects of the alpha adrenergic, it reduces the uterine blood flow. About the beta 2 adrenergic, it impairs the uterine contractility. هون حنحكي عن الليبر definition. احنا قلنا عنه سابقا انه في عنا 4 stages. So what is the definition of labor? The labor is progressive uterine contractions which leads to progressive cervical changes like dilatation that ends up by expulsion of products of conception, which are the fetus and the placenta. 4 stages: the first والsecond والthird والfourth. Okay. الفيرست زي ما قلنا احنا في عنا time of diagnosis of labor to full cervix dilatation. Second, from the dilatation of the cervix to the time of delivery of the fetus. And the third stage, which is the time of delivery, the placenta and the membrane. After this is the fourth stage, and during the fourth stage there is stabilization of the patient. The first stage is further divided to latent phase and active phase. About the pain pathway, the uterus, cervix, vaginal, perianal area كلهم في عندهم specific fibers which is innervating them. بالنسبة للuterus والcervix, it is innervated by the T10 to L1 fibers, and the vagina, it's innervated by L1 to S4 fibers, and the perianal area by the S2 to the S4 fibers. في البودندال nerve برضو كمان innervates by the S2 and S4 fibers اللي حنحكي عنها بآخر المحاضرة. وهيك أنا بكون كملت جزئيتي، وهلأ حيكون زميلي عدنان حيكمل عني. يعطيكم العافية.
يعطيك العافية، ما قصرتي. الو، يعطيك العافيه جميعا.
الله يعافيك دكتور، تفضل.
مش راضي يعمل عندي شير سكرين. حياة انت بدك تعملي شير ولا انا؟
اول اشي لازم هي تعمل stop presenting, stop your
أيوة.
share. حياة تمام، هلا المفروض انت بتقدر.
يلا. واضحة عندكم هيك؟
لا لسه ما طلعت لنا دكتور.
هي أول مرة صراحة أنا بعمل شير سكرين.
طب ثواني، انا هلا بعمل شير للسلايدز تبعونك وانت بتقراهم.
تمام، يعطيك ألف عافية.
اوكي مبين معكم؟ اوكي عدنان تقدر تبلش.
دقيقة
بس
خليني
حاول عشان ما يصير صدى.
يعطيك العافية دكتور. الصوت واضح هيك؟
تمام تفضل.
يعطيكم العافية. أنا اسمي عدنان شرفات، وإن شاء الله راح أكمل معكم اليوم جزئية المانجمنت أوف بين لحد الإبيديورال أنالجيزيا and difference between spinal and epidural analgesia and anesthesia. بالنسبة للmanagement of pain, the modalities of pain management are divided into two categories, which are non-pharmacological modalities and pharmacological modalities. بالنسبة للنون pharmacological modalities هم كثير، أو most important two things اللي هي education and psychoprophylaxis or اللي هي psychosocial therapy اللي هو بيجي بيعتمد على الفاميلي اوف ذا mother وبيجي بيعتمد على الدكتور. والشغلة الثانية اللي هي البيو فيدباك. هذول two most important non-pharmacological modalities for pain relief خصوصا خلال مرحلة اللي هي ال first stage of labor. الباقي كانوا بيجوا بيعملوا اللي هي بلاسيبو إفكت، يعني مثلا اللي هي الإيموشنال سبورت، الباك مساج، الهيدروثيرابي، ترانسكوتينيوس إلكتريكال نيرف ستيميوليشن، الأكوبنكتشر، الهيبنوسيس، الريلاكسيشن إن warm water which has اللي هي maximum temperature 37.5 Celsius. زي ما حكينا most of these modalities have provided inconsistent results and work best during the first stage of labor. الفارماكولوجيكال ميثود بتيجي بتعتمد على 3 شغلات، او اللي هي هم عباره عن 3 شغلات: parenteral narcotics, inhalational analgesia and regional analgesia. بالنسبه للparenteral narcotics هي عباره عن very limited efficacy for the relief of labor pain, works best during the first stage of labor. The most commonly used opioids is pethidine and rarely morphine. Others such as fentanyl and are limited to patient-controlled analgesia. بالنسبة لمفهوم ال patient-controlled analgesia هو عبارة عن جهاز وكانيولا مربوطة في مثلا اللي هي سرنجة فنتانيل، والبيشنت هي اللي بتيجي بتزيد الدوز أو اللي هي بتقلل الدوز حسب حاجتها أو حسب البين تبعها or other reasons for analgesia. بالنسبة للريميفنتانيل may be used for IV controlled analgesia when regional analgesia is contraindicated. هسه راح نيجي نحكي ان شاء الله عن الريجنال انالجيزيا والكونترا انديكيشنز الها، فبالتالي بالحاله هاي بنجي نستخدم الريميفنتانيل كاي في كنترولد انالجيزيا. بالنسبه للسايد افكتس اوف الناركوتكس include nausea and vomiting بالنسبه للماتيرنال، ممكن كمان اللي هي delayed gastric emptying فبالتالي resulting constipation, short term respiratory depression of the newborn, possible interference with breastfeeding حيث انه secreted by breast milk. هسه هون اللي هي المشكله للبرنترال ناركوتكس او اللي هي الناركوتكس بشكل عام انه it can cross بلاشنتا فبالتالي ممكن تيجي تعمل neonatal respiratory depression, reduced بالفيتال heart variability and impaired neonatal feeding. وفي حالة انه اذا كان في opioid overdose وعملت عنا السيمتومز اللي هي neonatal symptoms, الانتيدوت للناركوتكس اللي هي عبارة عن نالوكزون. بالنسبة للنقطة الثانية من البين ريليف اللي هي الانهيليشنال انالجيزيا. بالنسبة للانهيليشنال انالجيزيا we use اللي هي نيتروس اوكسايد. بالنسبة للادفانتجز تبعته quick onset, short duration of action, it's most suitable later on in labor or while awaiting epidural analgesia and cause lightheadedness, nausea, hypocapnia due to prolonged use, dizziness and rarely tetany and fetal hypoxia. الريجنال انالجيزيا او اللي هي الكور تبع المحاضرة اليوم هي عبارة عن local anesthetics injected directly into the spinal column اللي هي neuroaxial analgesia or by blockage of a nerve supplying a specific area. Neuroaxial analgesia is the most effective form of labor pain relief. It includes epidural analgesia, combined spinal epidural analgesia, and pudendal nerve block. بالنسبة لللمبر epidural analgesia is the most common form. It's important to note that uterine blood flow normally is from 700 to 900 ml per minute, اللي هو عبارة عن 12% of اللي هي maternal cardiac output خصوصا فترة الترم, and can be altered due to hypotension which occurs after initiation of epidural as it leads to sympatholytic activation. So adequate hydration prior to epidural analgesia من half an hour to an hour prior to analgesia is required. هسه هون احنا بس بدنا نيجي يوم بدنا نيجي نعمل هايدريشن, السلاين اللي بنيجي بنستخدمه اللي هو الرينجرز لاكتيت كبولس بتيجي بتنعطى الدوز تبعتها من 10 الى 15 ml per kg زي ما حكينا اللي هي الديوريشن قبل نص ساعه الى ساعه من الابيديورال انالجيزيا عشان تو افويد اللي هي الهايبوتنشن اللي ممكن يجي يصير. هسه اذا مثلا ما صار في اللي هي البروبر هايدريشن راح يجي ينتج عندنا اللي هي الهايبوتنشن. هسه بحاله الهايبوتنشن هاي we have to use اللي هي IV ephedrine to increase اللي هي blood pressure للمother.
Okay, so in summary, what happens is it's an epidural. So you're blocking everything at the level of L1 and below. So what you're doing is that you're blocking the sympathetic outflow from the higher centers to the pelvic vasculature. So you're inducing neurogenic shock in the lower part of your body. To avoid this hypertension, we expand the intravascular volume before initiation of epidural. That's in summary.
بالنسبة للإبيديورال أنالجيزيا زي ما حكينا هي the most reliable form of analgesia, pain relief during the first and second stages of labor. بالنسبة للمودرن epidural analgesia and includes an initial bolus of local anesthetic in addition to narcotics such as fentanyl or safentanil. بالنسبة للlocal anesthetics ممكن نيجي نستخدم اللايدوكين, بيوبيفاكين, روبيفاكين, بس أكثر شيء بيستخدم اللي هي اللايدوكين. بالنسبة للبلوك can be extended by injecting a higher dose of local anesthetic, thus enabling surgical anesthesia for CS or postpartum tubal ligation. هسه هون اللي هي بنيجي بنحكي عن مفهوم التحول من الابيديورال انالجيزيا الى الابيديورال انستيزيا عن طريق اللي هي زيادة الدوز of اللوكال انستيك اللي هي we are injecting للابيديورال space. بالنسبة للديليوت solutions can be used that allow ambulation, which is اللي هي walking epidural, where the goal is to avoid motor block in order to minimize any adverse effects on maternal expulsive force. هنا يعني احنا ليش بنيجي بنستخدم الابيديورال؟ لانه لها اللي هي ماينر بلوك للموتور سيستم، فبالتالي احنا ما بنيجي بنأثر على الاكسبلسيف فورس اوف ذا ماذر، لانه عندك اللي هي الليبر بيجي بيعتمد على اللي هي اليوتراين كونتراكشنز، فاحنا اذا عملنا موتور بلوك بيجي بيصير اللي هي زي كومبرومايز لليوترس، فبالتالي اللي هي ابنورمال ليبر، وممكن بيجي بيصير اللي هي برولونج. بالنسبة للفيرست stage of labor is not affected. However, the second stage is on average prolonged by 15 minutes with a greater chance of اللي هي instrumental delivery. يعني بيجي بصير prolongation للsecond stage of labor اللي هي من فترة cervical change إلى فترة اللي هي expulsion of the fetus. Indications for use of epidural analgesia include prolonged labor or oxytocin augmentation, maternal hypertensive disorders, multiple pregnancies, a high risk of operative intervention, and selected maternal medical conditions. Side effects and complications of epidural analgesia include fever, الهيديك، هاي اللي هي الهيديك اسمها اللي هي السباينال هيديك او اللي هي البوست بانكتشر. The risk is less than 1% due to accidental dural puncture leading to CSF leakage, which will decrease intracranial pressure. Little or no headache when supine, or severe when sitting up or standing. فبالتالي exacerbating factor او اللي هي الهيديك هذا بيجي بنوصف على اساس انه positional. هو عبارة عن self limiting, resolves within 5 to 7 days. ليش؟ لأنه هذا البنكتشر بالديورا بيجي بيحتاج إلى 7 days to be healed. الهول can be sealed by epidural blood patch. بالنسبة للتريتمنت لهم احنا زي ما حكينا هو عبارة عن self limiting. سيلف ليميتد، فبالتالي بس بدنا نيجي نستخدم اللي هي زي سيمتوماتيك ريليف عن طريق الاناسيدز، الناركوتكس، الكافيين، عن طريق التريبتانز or abdominal binder is used in treatment. ممكن كمان من الكومبليكيشنز اللي بتيجي بتصير او السايد افكتس اللي هي الباكيك، bladder dysfunction which can predispose to permanent damage to the detrusor muscle and hypotension زي ما حكينا قبل شوي. Other side effects اللي هي accidental total spinal anesthesia which will cause severe hypotension, respiratory failure, unconsciousness and death if not treated immediately. فبالتالي هون بنشتغل عن طريق اللي هي الاي بي سي. We have to secure the airways, breathing and the circulation. بالنسبة للhypotension is treated with IV fluids, vasopressors زي ما حكينا مثل اللي هي IV ephedrine and by positioning of the patient on her left side to avoid aortocaval compression. أتوقع هاي السندروم حكت عنها زميلتي حياة في أول السيمينار اللي هي due to compression للأيورتا والinferior vena cava by اللي هي الجرافيد يوتيروس. فبالتالي اللي هي أحسن تريتمنت لها أنه المريضة بتيجي بتنام على جنبها الشمال، فبالتالي ما بيصير في compression. Short-term respiratory depression of the newborn due to presence of opioids in all modern epidural solutions. فبالتالي حكينا إذا مثلا كان في respiratory distress بالنيوبور due to opioid بنجي نستخدم النالوكزون اللي هو عبارة عن antidote للأوبيويد. Contraindications to use epidural analgesia, coagulation disorders, local or systemic sepsis, hypovolemia, insufficient number of trained staff and increased في intracranial pressure. وهون في مقارنة سريعة ما بين الابيديورال اند السباينال. هسه بالنسبة للابيديورال احنا حكينا اللي هي انجكشن اوف اللي هي اللوكال انستيتكس ان ذا ابيديورال سبيس، whereas اللي هي السباينال injecting اللوكال انستيتيك ايجنت في السب اراكينويد سبيس. هسه بالنسبة للفرق بيناتهم اللي هي الأونست، حيث أنه الابيديورال slower induction whereas spinal is faster induction. بالنسبة للموتور بلوك بيكون less بالابيديورال and more بالسباينال. بالنسبة للديوريشن الابيديورال هو عبارة عن زي continuous كانيولا، يعني انه احنا بنيجي بنضخ اللي هي اللوكال انستيكس continuously، فبالتالي احنا بنيجي نتحكم بالديوريشن. اما بالنسبة للسباينال ليميتد ديوريشن، خلاص انت بتيجي بتحقن وبتيجي تطلع من السباين بالنسبة للتايتريشن تايترابل ان ابيديورال and in spinal it's not titrable. بالنسبه للبوست ديورال بانكتشر هيديك از ليس كومون بالابيديورا. ليش؟ لانه ما صار في بانكتشر للديورامتر. بالنسبه
ده اعترضك دكتور. العكس، it's more common in epidural than spinal. It's counterintuitive, but because in epidural we use larger needles. So if you use larger needle and puncture occur, it's more likely. In spinal usually we use a smaller needle and this needle is different shaped. بدل ما تكون بيسموها bevel زي هيك، بتكون pencil shaped هيك. So this splits the fibers, this cuts the fibers. If you cut the fiber, you're more likely to induce spinal headache. If you split the fiber, you're less likely to cause a headache. So epidural has more chance for severe headache. Okay?
تمام. هيك أنا أتوقع إني أكون خلصت جزئيتي. يعطيك ألف عافية دكتور، وهسه زميلي أسامة إن شاء الله راح يكمل معك.
Stop.
يعطيكم العافية.
الله يعافيك.
يا مشي. alright شايفين؟
دكتور بس اعملها expand للسلايد شو.
شايفين هلا؟
تمام.
We're going to talk about pudendal nerve block today. I'm your colleague Osama Al-Sabuni. Pudendal nerve block gets its name because of local anesthesia such as lidocaine is injected into a pudendal canal where the pudendal nerve is located. The pudendal nerve provides most sensation and function of the external genitals. the urethra, the anus, and perineum. It also controls the external anal sphincter and sphincter muscles of the bladder. Blocking these nerves, Blocking these nerves allows quick pain relief to the perineum, vulva, and vagina. Pudendal block is usually given in the second stage of labor, just before delivery of the baby. Nerve roots, pudendal nerve, are S2 and 2S4. All right. How to locate the pudendal nerve and block it? This is the accepted method for performing a paravaginal pudendal block. Position your index finger or middle finger on the ischial spine and run the needle guard in between your index and middle finger. Place the end of the needle guard 1 centimeter posterior and medial to the ischial spine. The guard can then be unhooked and the needle advance 1 centimeter into the tissue. Now we're going to talk about local anesthesia. Local anesthesia provides numbness or loss of sensation in the small area. It does not, however, lessen the pain and contraction. Some local anesthesia that is used in labor, such as lidocaine, bupivacaine, mobivacaine, and ropivacaine. Okay.
دكتور اطلب منك طلب شوي، اسف على المقاطعه، بس بعد فمك شوي على الميكروفون.
انا اسف. اوكي هيك كويس.
احسن شويه.
تمام. Anesthesia for cesarean delivery. Most C-sections are done under regional anesthesia, which numbs only the lower part of your body, allowing you to remain awake during the procedure. Common choices include a spinal block and epidural block. In emergency, مش عارف إذا واضحة عندكم ولا لا. In an emergency, general anesthesia is something needed.
Yes, because general anesthesia is faster to initiate. Spinal needs at least 5 to 10 minutes. Epidural needs 15 to 20 minutes. General anesthesia, you can start it within 20 seconds. So if you really need to deliver the baby and get the baby out, you have to resort to general anesthetics.
Sure. The choices of anesthesia depends on the indication for the CS or C-section, the urgency of the surgery, the patient's medical conditions, the desire of the mother, the presence of or absence of pre-existing epidural catheter for labor, pregnancy-related complications, the presence of any contraindication to the regional anesthesia. General anesthesia. General anesthesia ليش هيك طالع عندي؟ مش عارف. Okay. General anesthesia may be indicated in these situations when there is extreme urgency and no pre-existing epidural catheter, when there is contraindication for the regional anesthesia, when regional anesthesia has failed, when significant hemorrhage is expected, when there is a maternal refusal of regional techniques. Now for spinal cesarean, bupivacaine is the most used, small dose of intrathecal fentanyl. Epidural cesarean, 2% lidocaine with epinephrine is the most common anesthetic for cesarean. 0.5% bupivacaine or ropivacaine has much lower onset than lidocaine, but decrease the risk of cardiac toxicity. Fentanyl and morphine are also providing good analgesia, and standard spinal bupivacaine 10 to 15 milligram, adding the intended dosing of the epidural.
Okay, so you don't have to know the doses exactly. You as GPs, all you need to know is that in both spinal and epidural, we both give a local anesthetic plus minus an opiate. Usually it's a ultra short acting opiate such as fentanyl or remifentanil. Okay, you don't need to know the doses, but in general, that in epidural, you usually give higher doses and higher amounts than in spinal. Because spinal is intrathecal, immediate.
Okay. Now, for neural, axial is preferred over GA or JRCD unless coagulopathy, profound maternal hypovolemia, urgency for the procedure due to the fetal status, patient refusal of neuroaxial anesthesia. Now, for postpartum pain management, there are two sources for pain in the labor procedure. One of them is uterine due to retraction, and the other one is perineal due to the distension or episiotomy. And plus minus abdominal scar if it exists. How to manage perineal pain? By putting warm compressions, avoid constipation, local anesthesia such as lidocaine gel. How to manage other types of pain? Paracetamol is usually taken regularly for 2 days, plus minus NSAIDs, plus minus a narcotic, especially if operative delivery is C-section. And thank you very much.
Okay, thank you to the three of you. So let me just take over for a second.
Sure. 1 minute.
That's okay.
All right.
Okay, so why are we talking about anesthesia, although we're obstetricians? Well, because most of the ladies that will present to an obstetrician for delivery, they don't present to us because we're better at getting the baby out. They simply do because we're better at controlling their pain. In general, studies have shown that delivery by a midwife has lower risk of overall complications, whether fetal or maternal, than it does by an obstetrician. There is lower risk of instrumental delivery and low risk of cesarean section when there is a midwifery-led unit rather than an obstetrician-led unit. But ladies still show up to the obstetrician because of pain. One of the great advances over the last few years in regards to hospitalization is pain control. The problem with pain control in regards to obstetrics are twofold. First is that you have to watch out for the physiological changes of pregnancy and plus cross of the drugs through the placenta. Two is that you have multiple levels of pain, and each stage in the progress of labor have different sources of pain and different modalities to control this pain. In general, you should consider that there is either vaginal delivery or cesarean section. In regards to vaginal delivery, there are three main stages for control of pain. The first, second, third, and puerperium. In regards to both first and second, we can either use narcotics, Intonox. Intonox is nitrous oxide and O2 at 50 to 50 concentrations, or ideally an epidural. Or an epidural. The ideal one is epidural. Why do we prefer epidural? Because it works best for both stages. If we need to do an operative delivery, either by cesarean or instruments, we can escalate the dose of epidural and cause more motor blockade and induce it. And we can customize the doses according to the patient's wishes, and it will work even to the rest of the stages. Narcotics, on the other hand, are usually not quite effective We have limitation on the doses and the frequency we can administer these doses. They can cause maternal respiratory depression and delay in gastric emptying. And if they're given near the second or third stage, they can induce respiratory depression on the fetus. Please remember that naloxone is the antidote. And naloxone is very short acting, 2 to 3 minutes. So usually when you need to give naloxone, unfortunately, you'll give frequent doses of naloxone. So it's not just one dose and it works. So for the first stage, we can either be systematic or block from T10 to L1. In the second and third stage, we need to block around from L1 to S4. So the cervix and the vagina. This can either be done by if epidural was already in place or pudendal blockade. Okay, remember that the pudendal nerve is the one that's responsible for S2 to S4. It supplies the lower 2/3 of the vagina and the perineum and the anus. So if you need to use an instrument, if there is anus sphincter repair, if you need to do an episiotomy and repair it later on, pudendal blockade is very good for these issues. And the pudendal nerve exits through the greater sciatic foramen and re-enters through the lesser sciatic. So it loops around the sacrospinous ligaments, which is from the spinal scale spine to the scale to the sacrum. So we go behind it and we block this area around this sacral spine. And this will give us pudendal blockade. Also, do not remember that most ladies do not stop complaining of pain just by delivery. So the fourth stage of labor, otherwise called puerperium, is quite important to be managed. Most healthcare providers, unfortunately, forget these stages of labor. Please do not. So what should we do in the fourth stage of labor? It depends on the mode of delivery. If it's just vaginal, the pain is just uterine. So again, T10 to L1 and perineal. If it's cesarean, there are 3 pains. There's uterine, there is vaginal, usually there is uterine and there is abdominal wall. So around T9. In general, ladies post-op or postpartum will need a paracetamol for general systematic management as a baseline. They'll also need a local anesthetic if there is vaginal pain. Usually we give lidocaine, in gel form. We can also use NSAIDs. And if it's operative delivery or there's severe pain, we can even use opiates. The opiate that we generally use for systematic management in obstetrics is called pethidine. That's the general name. The Americans know it in another name called meperidine. So meperidine and pethidine are the same drug. In regards to cesarean section, if epidural was already inserted, all we do is that we escalate the dose of epidural, but usually 95% of anesthesia for cesarean section is spinal. Spinal is faster. It works for around 2 hours because it's given as a bolus, unlike epidural, which is given through a catheter, through a continuous infusion, so you can extend it. That's in comparison to the epidural. In comparison to the spinal, in comparison to the general anesthesia, this GI suppression, airway will still be maintained by the mother herself. So there's less concerns of loss of airway control. And less concern of aspiration in general. And even after recovery, there's less risk of VTEs and constipation and ileus. So that's a general overview of anesthesia and pregnancy. In general, you do not need to remember the exact doses of the different drugs, lidocaine, marcaine, or pivocaine, and so on. But you need to remember the antidotes. We said that opiates, the antidote is naloxone. Does anyone remember what's the antidote for local anesthetic? Does anyone remember the antidote for local anesthetics?
Lipid doctor.
Yes, full lipid. نفس اللي بعته for total parental anesthesia nutrition. Because these are lipid soluble, so you try to emulsify them within the full lipid and they'll be digested later on. Remember that local anesthesia can happen due to increased dosing. So if you give a higher dose or venous absorption. So if accidentally you give it within a vein or a venous plexus, you'll also cause toxicity. And they usually present with bradycardia because of cardiac block. And these patients are already admitted to the ICU due to these. There is another issue that your colleague alluded to briefly, and it's not quite important, frankly, for you as GPs, but for those of you who read it and did not understand it, is total spinal. The difference between spinal and epidural is where you get the main difference, is where you give the analgesic. So if we consider this is the spine, and that's the sacrum. In general, there's the dural matter. The spine will end around L1, L2. That's the spinal cord proper. So in epidural, you create a potential space just before the dural matter. In spinal, you give it intrathecal, so on the CSF itself. In total spinal, instead of blocking the levels you want from let's say from L1 to S4, what happens is that the anesthetic will migrate upward. That's either due to abnormal positioning of the patient or scarring. There are different reasons, you don't need to know. So what happens is that you start blocking the cervical portions of the spine around C6 and C5, and you'll cause two issues. First, you'll suppress the respiratory centers in the spine, and two, the cardiac centers. So the patient will not be able to breathe, and they'll have cardiogenic shock, neurogenic shock, sorry, by suppression of the cardiac muscle indirectly. And that's one of the very dangerous complications that might occur, although they're rare. I've never seen one, thankfully. And that should sum it up for our today's presentation. Thanks to the three of you, Osama, Adnan, and Haya. Open for questions right now. Do any of you have any questions in regards to obstetric anesthesia and analgesia?
دكتور بس بعد إذنك ممكن سؤال أنا عدنان.
تفضل.
بالنسبة لل post-dural puncture headache مش الباثوفيسيولوجي إلها اللي هي عبارة عن puncture بالديورو ماتر فبالتالي بيجي بيصير CSF ليك فبالتالي بيصير الهيديك؟
يس.
طيب أنا بالنسبة لنقطة النيدل الصراحة أنا ما فهمتها هاي، بس أنا اللي ليش حطيت إنه more frequently وليس frequently؟
فاهم، في محلات بيكتبوها صح.
أيوة.
اوكي بس مبدئيا it's more common in epidural. why؟ هلا عشان نفوت على CSF usually they use a 29 gauge needle. 29, 26. Okay. اوكي طبعا كل ما زاد الرقم الكيج كل ما صغرت النيدل. تمام. وشكل النيدل اصلا بسموه pencil shaped اللي هي شكلها زي شكل القلم الرصاص. So it splits the fibers. So although all spinal anesthetics do puncture or do go through the dural matter, the puncture itself is very small and usually self-sealing. So the likelihood of spinal headache occurring afterwards is low. بالابيديورال بيستخدموا بالعادة 12 to 16 gauge. Okay, it's around 3 to 4 times larger. And they have, because they go through the skin, they have to go through using a bevel-shaped needle. Okay, اللي هي شكلها هيك زي الإبر العادية اللي بتشوفوها. So they're larger and they cut instead of splitting the fibers. One of the complications of epidural is that you can accidentally go through the dural matter because you're doing a blind surgery or blind procedure. You're doing it by feel. يعني كيف الدكتور بده يعرف هو dural ولا intrathecal ولا epidural؟ بحس بالبوبس. بحس أول إشي بالليجمنت فلافم إذا one pop يعني هو قبل الابيديورال ببلش. إذا two pops يعني هو ضرب الثيكال ماتر وضرب الديورال ودخل على intrathecal matter. Although all spinals go through the dura, the damage is small and it rarely presents with spinal headache. But although epidural anesthesia should not go through the dural matter, sometimes it does. And if it does, the damage is larger and it's more likely to present with headache. Okay? وضحت ولا مش كتير؟
لا تمام.
So in general, all you need to know is that it's around 1 to 2% of ladies that will have this presentation. We usually treat it conservatively, but bed rest and analgesics. Paracetamol usually we first try it, then we go for narcotics. If it does not resolve in 5 to 6 days, usually the anesthesiologist will do an autologous blood patch. So they'll take blood from the lady herself and inject it into the site of the dural puncture so that it coagulates there and seals the puncture, and the puncture later on will heal by itself by scarring. Any other questions? Okay. So thank you to the three of you again for your presentation. I'll see the rest of you for our clinical session at 11 p.m. At 11 a.m. Sorry. Have a good rest of your day.